In this video lecture, we will discuss about why understanding occlusion is important. Occlusion has been debated over decades. Over multiple research has been done and is one of the most talked about topic in dentistry. However, before you decide why you should learn about occlusion, you should ask the same question which I ask when I'm learning anything new skill. How is going to benefit me in clinical day-to-day practice? So let me ask you a few questions. Have you had to replace amalgam with another amalgam or a composite and end up carving amalgam or composite newly restored tooth, so much so that it has created a small ditch in order for you to fit the occlusion and the teeth meet, because patient kept saying it's high, it's proud? Have you had a situation where you prepared last standing tooth and you know for sure that you have done enough occlusal reduction, and when the crown comes and you try and fit it and you had to reduce occlusion so much so that sometimes it becomes almost near perforation? Have you had a situation where you come across a patient who all the time breaks or fractures their teeth or their restorations or old fillings? Would you like to treat patients with more predictable treatment and more comprehensive treatment? If any of the above questions you have answered yes to, then this course will help you answering those questions. Let's have a look at this one particular tooth. What can you see when you're looking at this tooth? Apart from the fact that it has a broken cusp on the palatal aspect, you can see that there is a faceting on the amalgam, not just one, multiple faceting. There is a small crack line appearing. Now, the question you should ask yourself is why this fracture has happened. And many times when we are doing day-to-day dentistry, we are very much concentrating on fixing the problem but not the cause of the problem. So one of the reasons this fracture has happened is just because it's got a large amalgam, and we know that amalgam teeth which has got large amalgam is prone to fracturing. It could be that someone done restoration on the opposing arch and left it high. It could be that that cusp is non-working side contact. It could be that it's just a cyclic fatigue and it just fractured. So there are multiple reasons. However, with knowledge of occlusion, you may be able to predict and prevent some of these failures. Let's look at this tooth. Now, of course, you can say that there is a vertical fracture on this tooth, and it could be because of amalgam. Again, amalgam treated teeth are very well known to have cracks in them. However, can you see a faceting on the palatal cusp? And that faceting could be a non-working side contact. I am not saying that the non-working side contact is pathological. However, knowing that that tooth has a non-working side contact may be helpful. It could be that it's a 7 and it has a slide, and when patients grinding or bruxing, is grinding in that position and that tooth is coming across unfavorable load, and of course we end up having that tooth extracted. However, what opened my eyes was this case. This gentleman came to see me for a routine checkup, and I have a habit of doing occlusal assessment for almost all my patients, even for routine checkups. And what I've noticed is that this particular tooth had a large amalgam filling, it had a mesial crack line, and it had non-working side contact on the palatal cusp. And I discussed with this patient and I told him that, it would be best that we do some cuspal coverage for this tooth. However, patient was going abroad and he decided to delay the treatment, and within few months he came back with this broken tooth, and unfortunately this tooth had to come out. Yes, you can possibly do crown lengthening, try and save the tooth. However, it will be always have a very guarded prognosis if you at all manage to save it. And in my opinion, this tooth was, I could have predictably saved this tooth. So let's look at why teeth break. So one of the reasons teeth break is because of unfavorable load. Now that could come from the way the patient closes their teeth, the way the patient grinds or brucks, or sometimes some of the restorations are proud, and that can cause unfavorable load. Not all proud restorations can cause issues. And that's why, again, dentistry is so beautiful. We are working in an environment which is so adaptable that we can treat patient and we have so much forgiveness from the mouth. However, sometimes it can come across where you're leaving the restoration high or proud, the opposing tooth tends to break. The other reason teeth break is just cyclic fatigue. And that could be because patients using it more often, and this happens when patients are occluding more often. And I always tell everyone that occlusion is not an issue. When patient occludes to teeth, and if that's not favorable, that's when it becomes issue. So if patient's parafunctioning, we know that the patient is going to occlude that teeth for longer and in a different way than patients are functioning, and that could be one of the reasons. The other reason is concentration of force, and one of the classic example is rotated or twisted lower central incisor, and you're doing veneer on upper central incisor, and patient keeps knocking that veneer off. And learning and knowing that to do veneers on the upper arch, it may be worthwhile discussing with patient orthodontic treatment to get the occlusion correct for long-term success of your veneers, or modify your veneer in such a way that the occlusal load is not concentrated and it's more favorable. And that leads to a discussion where we really need to understand that, we're doing dentistry day to day, and many times we don't even think about these things, and dentistry works. And that's the reason what I said before, that we are very, very fortunate that we're working in an environment which is very adaptable. However, when you're looking at sometimes you do a treatment, it works, and sometimes you do a treatment, it doesn't work. Or sometimes some patients have more fracturing than other patients. And that's when you need to look at why or what is the difference between function versus parafunction. Because when patients functioning, anything would work. Whatever you do will most likely work. However, we are learning about occlusion in depth to avoid failures in patients who are parafunctioning. And this is a very important key aspect, because when you're chewing, to chew, you do not need an adequate occlusion. You can function, you can chew quite normally, even with a high restoration or inadequate occlusion. However, if you want to protect your newly restored teeth, then you need to learn about occlusion to prevent failures in patients who parafunction, or when patient parafunctions. Because everyone parafunctions at some point in their life. Sometimes some patients, they continue parafunctioning, sometimes patients stop. So let's discuss different variations or differences between function versus parafunction. So first of all, when you function, the teeth contacts are very, very less than when you parafunction. It's almost 10 times less when you're functioning. So mainly when you're functioning, the teeth are in contact mainly when you're swallowing or when you are chewing. The study shows that right at the end of the chewing cycle, you may have a very small slight contact with the teeth, opposing teeth. However, there is no substantial load applied, and that's why this contact is negligible. The other thing you need to understand is magnitude of force. That the study shows that, when you are functioning, the load is much less than when you're parafunctioning. And that goes back to the previous slide where we discussed, concentration of force or cyclic fatigue is really important in preventing fractures. The other important aspect is direction of the force. And most of the time when patients are functioning, the direction of the force is vertical to the teeth. Whereas when patients are parafunctioning, the direction of the force is horizontal, which is much more detrimental to the posterior teeth. Because posterior teeth are not designed to take load horizontally. It's designed to take load vertically. We will discuss about different levers. However, you need to understand that in function, we create something called class 3 lever, which is less harmful than class 2 lever because it applies a lot of forces. The muscle contraction is isotonic in function, whereas isometric in parafunction. The other thing we need to understand is when patient is functioning, you have your neuromuscular structures working much better than patients parafunctioning, which is usually at nighttime or when you're concentrating doing something, because all your energy and the brain power is used in order to do that activity. And that's why when you're parafunctioning, it's almost a subconscious act. And because of that, you don't have that much neuromuscular protective mechanism. The mandibular closure position is when you are closing is ICP or MI, maxillary intercuspation, whereas when you're parafunctioning, you don't parafunction in ICP. And that's why it's very important to know that although you've done restoration and you asked patient to close their mouth and checked that it's not proud and it's fitting in their closure MI, that's not enough, because when patient's going to do parafunction, they may not parafunction in the same position, or they will not, most likely. They will parafunction in eccentric position. And that's why sometimes you may see that you check the occlusion, you know for sure that it's not proud, but still the filling keeps breaking. And that could be various reasons. You created probably non-working side contact. You have created a slide in that restoration, or patient slides from CO to MI and that restoration comes in a way, and that's why patient keeps fracturing. So there are multiple reasons. I'm not suggesting that occlusion is only reason why teeth breaks. So this is very important. It could be that the teeth are inherently weak or the restoration is weak, but knowing and understanding occlusion will help in increasing the productivity or longevity of the restoration. And last point is that, the pathological effect of function is almost none, because it's a normal function and our body is evolved to perform that normal function. Whereas the pathological effect of parafunction varies in different patients, because some patients are adaptable to parafunction, and that's why you would see that they have severe wear but no pain in TMJ or no pain during function, because their adaptability is quite high. Or there are some patients we have minimal wear, but they have pain in TMJ and their muscular pain and everything. So patient's adaptability is very, very important. This is the very famous quote quoted by Passault in 1962, that the occlusion is one of the basic building stone of dentistry. And it's been decades since it's been said. However, still, why occlusion is so confusing? One of the reasons occlusion is very confusing is because it's not very well taught in undergraduate level. There was a study done where the questionnaire was sent to the universities asking how many hours of occlusion specifically has been taught. Some of the universities did not teach occlusion as a separate subject. Occlusion was taught as a part of the different disciplines, whereas some of those universities were very good and teaching for many hours. So there is inconsistency in teaching and training. There's too much information that seems difficult to relate when it comes to general dental practice. And a lot of theoretical talk is gone on, and because of that, people have developed a lot of different opinions. And when it comes to using opinions, it's not just the opinions. People who had different opinions use different terminologies to describe different things. And one of the examples was the definition of CO in 2000 was different than definition of CO right now. So if you look at the glossary of prosthodontic terms in 2000, CO and CR was same. And that's why if you are discussing occlusion with someone, one of your colleagues who graduated before 2000, and you're describing them what is CR and CO, they might get confused and they might, argue back saying that, they are the same. However, the terms, the way it's described has changed. More importantly, there is not much scientific evidence as to what we do, how it works and where it works. We have evidence suggesting, that canine guidance works and so as the group function works. We have evidence suggesting that you don't need a Facebook, but we have evidence suggesting you need a Facebook. We have evidence suggesting you don't need to really use semi-adjustable articulator or articulators per se. So why you would bother, learning about occlusion where, evidence are conflicting? More importantly, as we discussed before, conformative dentistry works. Most of the time what you do works. And that's why you may think, why should I bother learning? And then lastly, it requires a lot of practice. Learning and just reading books is not enough. You need to really apply your knowledge. And this is with anything new skill you learn. And same thing with occlusion, that it applies, it needs practice. So what are the mistaken beliefs when it comes to occlusion? One of the beliefs, people believe that it's only for elites or specialists, doing occlusion, treating cases with different occlusal schemes, or doing full mouth reconstruction even is for specialists or people with special knowledge about it. The other misbelief people have is that it's about canine guidance. If you build canine guidance into their mouth, patients will be fine. However, it's not. And the other misbelief people have is that, you only need to learn occlusion if you want to do full mouth reconstruction. I don't want to do full mouth reconstruction. I just want to do simple general dentistry, and that's why I don't really need to have a knowledge of occlusion. But that's not true. And the other complexity, other misbelief people have is that the occlusion is very complex. And one of the reason people believe that is because it has been made complicated. People who's teaching occlusion, they made occlusion complicated. And I'm hoping to make it simple for you. So, you looked at the issues related to why, there is a confusion, why people are, what mistaken beliefs they have. And as you said, as I said, that, conformative occlusion works. So why you should learn about the occlusion? So let's look at some of the benefits of learning about occlusion. So one of the benefits of learning about occlusion is be able to treatment plan cases more comprehensively. And I'm not talking again about full mouth reconstruction. Of course, that will help. However, if you have over-erupted tooth and if you have broken teeth and patients keep breaking, how to treatment plan that cases, it will help you doing that. And we will learn about this in the following videos in more detail. It will help you planning those aesthetic cases where occlusion is so important that without knowledge of occlusion, you will have higher failure because your veneers might keep chipping or breaking or delaminating, or you might have a patient who cannot function very well. By learning occlusion, what you will have is you will have more predictability in restoration because of the above reason. And because you don't have to see patients again and again for more adjustments, you will be able to produce, or you'll be more productive. Because of all above reasons, patient will be reporting more comfort and more satisfaction in their treatment. And when patients are satisfied and comfortable, our stress reduces. So I hope above benefits outweighs the pain you need to go through to learn about occlusion. Again, during this whole video course, I'm going to make sure that I'll try my best to make learning about occlusion as simple as possible for you. So what is our aim? Our aim is to restore patients' function in such a way that when you are finished with patient, you look at the case and you think, you have restored dentition so the patient's function without showing the sign of fracture, dysfunction, pain, mobility, and more importantly, failure of aesthetic. So you should be able to look at the picture on the left and visualize the results of right or even better and show it to patient confidently that you are able to do this. And I'm hoping that during the various learning courses, you will be able to learn this and you will be able to implement some of the techniques and skills you learn into your day-to-day practice. So in this video, you learned why occlusion is important. We discussed a few questions and you will get those answers of those questions in follow-up videos. Next video, we are going to discuss about various terminologies used in occlusion.